Yaghmaie, Associate Professor of Medical Genetics at Tehran University of Medical Sciences and head of the leading house for Iran-North America Academic Partnership, which has planned and organized this series of educational programs. First of all, I would like to thank you for participating on our webinar, and we are honored to have you all here. This is actually the third part of the webinar entitled How I Treat a Set of Hematologic Malignancies. It's a great academic opportunity for Iranian hematologists and fellows to interact as well as share and exchange their experiences with Iranian American experts in the field of hematology. Here I should express my gratitude to Dr. Maziar Shadman, Associate Professor of Medical Oncology at the University of Washington, the Appraise to Raise team, and Tehran University of Medical Sciences Vice Dean for Educational Affairs of International Campus for their great help and support for making this program possible. I should also add that we will provide the certificate of attendance and award to the participant of this webinar who will be present for more than half the time of this session. Here I pass the microphone to Dr. Shadman to provide you with some introductory information about this program and also to introduce our invited speaker, Dr. Ehsan Malek. And later, Dr. Tavakoli, our moderator, will start the program. Dr. Shadman, microphone is yours.
Thank you, Dr. Yaghmaie. I would just like to say hi to colleagues, and in the interest of time, since we started a little bit late, I will just introduce my very good friend, Dr. Ehsan Malek, who is our speaker today. Dr. Malek is an assistant professor of medicine at the Case Western University of Cleveland, Ohio. He finished and obtained his medical degree from Shahid Beheshti University in Iran. He did 2 years of postdoc fellowship at the University of Southern California and started his medical residency for internal medicine at University of Utah. He then moved to Cincinnati when he finished his fellowship at the University of Cincinnati and then joined the faculty at Case Western. He serves as a director of the myeloma program. His focus is only on plasma cell disorders. He's very active in clinical and translational research. He leads a number of clinical trials from novel agents to immunotherapy and CAR-T, and also has a focus on microenvironment research as his translational focus. He's a member of a number of committees, NCCN guidelines, and ECOG, and of course, author for many publications. Thank you very much for accepting this invite and for talking about multiple myeloma. Thank you very much.
Hello to all dear participants. Welcome to our webinar. Sorry, I can, Dr. Shadman, can I speak and no or no?
Yeah, I can.
Okay. Yeah. Sorry. Welcome to our webinar. This is the third session of How I Treat Hematologic Malignancies series, which is about multiple myeloma. My name is Sahar Tavakoli, hematologist and oncologist from Tehran University of Medical Sciences. I'm working in Shariati Hospital, Hematology and Oncology, Bone Marrow Transplantation Research Center. Dear participants, please pay some attention to some point that was mentioned before. If you need international short course certificate, you have to complete the online registration form that is entered by my colleagues in the chat box. Please pay attention to some information that is entered in the chat box, please. And if you have some question during the program, you need just write it down, but we prefer you be more interactive with us. We prefer to hear your voice. So you just need tap on hand raise and so icons, and we can connect it to you. Firstly, I would like to say special thanks to my best friend, Dr. Marjan Yaghmaie, for her all extra effort to providing such a fantastic educational program. Thank you, Marjan. And I would like to appreciate Dr. Maziar Shadman for your kind appropriate for your kind cooperation. Thank you so much, Dr. Shadman, for your all great help every time we need. We all are honored to have you here. And at the end, Dr. Malek, dear speakers, it's our great pleasure to have you here, and we are all ears to you. So you can start, Dr. Malek.
Thank you, Sahar. Thank you. Very good, very good. I would appreciate everybody, especially Marjan, Dr. Yaghmaie, and Dr. Tavakoli. Thank you so much for having me. I think it's Friday evening at Iran is a very nice deja vu, really. By the way, the disclaimer, so let me share my slide, share a screen, in fact. Then we go from there. Beautiful. So the disclaimer is I'm a graduate of Danishgah Milli, and this is Danishgah Tehran. So that's Haftarchari Danishgah Shahid Beheshti. So whoever is Haftarchari, they can raise their hand. I know a few of them there. So I would start. So I want to give a very brief picture of really different stage of myeloma. What is the state of art treatment and what modalities is coming along, and I think Sahar also has some feedback at the end that what is available and what really we can bring to patients, myeloma patient in back home in Iran. And I think I will go around 40 minutes just talk, and I would like to open the session for questions and comments and joke if you have or so. So I'm going to talk about a little diagnosis. I think the in last few years the paradigm of diagnosis has slightly changed and risk stratification. The treatment modalities for newly diagnosed myeloma as well as relapse myeloma, transplant eligible, transplant ineligible, upcoming therapies, monoclonal antibodies, anti-CD38, anti-SLAM7, and so forth. Especially what is the modality for frail patients and for fit patients and so forth. Another one for after first relapse, that is very important. That is the best opportunity to put patients in the long remissions. And then we have later relapse options that usually there is more newer therapies. However, the rate of success comes down significantly. So let's go through I have a few slides here. So I remember the first myeloma patient that I saw, it was 1990, probably 8 or 9, perhaps in Talagani Hospital in Hematology department. And in that time, there was no free light chain, and there was no free light chain even in US, I think. And we had a serum electrophoresis, and is the first result of serum electrophoresis that I saw and mesmerized me. And somehow by destiny, I came back to this disease. Right now, I do exclusively myeloma and so forth. So as you know, the plasma cells, they make antibodies, and this is part of our immune system. We have a light chain and heavy chain, and they assemble the whole antibody. Somehow, one of the plasma cells, they start to be cancerous and growth clonally and produce only one type of antibody. So this antibody causes the MS spike, or a spike means that you have a one monotonous population of antibody in the electrophoresis. And then you have a free light chain assay also that I know that in Iran, we check very frequently. So the idea is this is a free light chain. This is not the light chain that attached to antibody. And the idea is plasma cells, basically, they are not able to assemble whole antibody together, that only they can secrete light chain. And then you can measure in plasma, in the urine, and they filter freely through the glomeruli in the urine. As you know, antibody is much heavier, so in the healthy glomeruli, it should not be filtered, basically. And then around 10-15% of patients, they only secrete light chain, so they call it light chain myeloma. So it's important to order both of them at the same time for any setting, even relapse setting. If you have a, let's say, IgA myeloma MS spike of 3 grams per deciliter, it's very important to check free light chain, because there is a phenomenon called light chain escape, that your MS spike stayed the same, basically heavy chain stays the same, but you have a rapid rise in the light chain. It means that myeloma cells, they are not able to assemble the intact antibody, and only light chains goes up, and that's the sign of explosive relapse and poor outcome, in fact. So coming back to diagnostic criteria, so around 2015, there were 3 major criteria was added to classic CRAP criteria as a diagnostic items for this disease. As you know, CRAP, the high calcium, renal failure, anemia, and bony lesions, these are the main items that we call it end organ damage that you have to differentiate multiple myeloma from a smoldering myeloma, or in other words, whether you need treatment, upfront treatment for this disease or not. In 2015, we add another 3 items that they are not end organ damage. One is if you have the plasma cells more than 60% on the bone marrow. This is the heavy disease burden that in 6 months, 1 year, end to have a basically end organ damage. So the idea is we can start them on therapy to prevent end organ damage. And another one is MRI lesions. So historically, skeletal surveys, we were doing from the very old time, but the idea is around 20-30% of time, we cannot recognize lytic lesions on a skeletal survey. So translation is, if I see a patient with a smoldering myeloma, so-called a smoldering myeloma based on a skeletal survey, and I don't do advanced imaging, CT, MRI, PET CT, or any of those, then around 20% of my patients, in fact, they are multiple myeloma that I'm not treating them. And these are the patients that they're going to come 6 months, 1 year down the road with fractures, high calcium, and so forth. So it's very important that we use advanced imaging. And another, the myeloma defining event is a light chain ratio, basically high, whether lambda to kappa or kappa to lambda more than 100. These are the patients that the majority of them, they end up with light chain nephropathy less than a year. So the idea is why we are not starting treatment to prevent renal damage, that, the nephron loss, the majority of nephron loss, in fact, is irreversible. The creatinine that we measure is not a true value that reflect nephron loss. So this is a slide that I put together for reflecting different modality of imaging. A skeletal survey, I would say, is substandard in 2021 for recognizing different aspects of myeloma, clinical aspects of myeloma. When you have a spine problem, only modality that it can be helpful is MRI, really, because the subtle lesions in the epidural space, nothing else can pick up on that, even PET CT and so forth. So you need an MRI as a detailed exam anytime that you think about a spine, and a spine lesions, a spine fractures, and a spinal cord compression. Worse than that is the major source of morbidity and, in fact, mortality that we can prevent with a small dose radiation. Many times we can prevent a small brewing lesion in epidural space and prevent a fatal outcome. So this is important that you use MRI very strategically. Other modalities, I know what is the insurance payment or availability of other advanced imaging, whole dose, basically whole body low dose CT, the same that we do low dose CT for lung, is the same with whole body or whole body MRI. These are advanced imaging that you can use. If really you don't have access to any of those, in terms of you can't order whole body CT or something, you really focus on axial skeletons and the proximal, like shoulder and hip and pelvic and spine, whole spine, and 95% of lesions that are there. So you're good to go, and you don't need contrast really for bone. So this is about imaging. We had a revised ISS staging system that, international standard staging based on albumin and beta microglobulin. It's quite old staging system that um, with the new knowledge, with the high-risk cytogenetics, so we revised that. So the idea is whoever was a stage 2 right now, if you have any of 3 modalities of high-risk cytogenetics, means 17p, 414, and 1416, it's going to upgrade to a stage 3. But myeloma, regardless of a stage, is treated almost the same, in terms of staging. You have solid tumor, stage 1, 2, 4, whatever. Multiple myeloma, by definition, is multiple focus at diagnosis. So it's metastasized, widespread through the bone marrow based on definition. So it's not that matter of what systemic therapy we're going to do, a stage 2 versus a stage 3. But in terms of prognostic, I think we had such improvement in cytogenetic knowledge that we could revise the staging system. So this is the overall, the big picture of whatever we have. As you know, right now we have 16 FDA approved, or 17, in fact, FDA approved regimen for myeloma. Unfortunately, it is incurable. So still we cannot eradicate myeloma with any modality of therapy, even CAR T-cell bispecific that are the most modern one. You have immune modulatory drugs that thalidomide-based, proteasome inhibitor that Velcade, Nilaro, and carfilzomib, basically Exazomib. And then steroids, prednisone, Dex, and monoclonal antibody that really they've been game changers since, I would say, 5 years ago. The majority of them are anti-CD38, whether it's isatuximab or daratumumab, and also anti-CS1 or SLAM7, elotuzumab. Elotuzumab doesn't have a single agent activity against myeloma. So I would say is not as efficacious of anti-CD38, but is a valid mechanism of action that sometimes we use in combination with other agents. Of course, alkylating agents that historically were very important in myeloma, and somehow with this avalanche of novel therapies, really they got neglected. But I think we have a resurface of these alkylating agents by a new FDA-approved drug that was done, I think, around 6 months ago by melfulfan. So the idea is the same melphalan, we have a new delivery system into the myeloma cell. So still transplant is a standard of care, high-dose melphalan. Cytoxan is a nice option, especially even in relapse setting. I'll go through the data that Cytoxan really is not that much usable in the front setting, but Cytoxan still is a potent anti-myeloma agent that many times we can use for salvage. And I would say quite often we forget this, with history is very important. Sometimes these new agents and this and that, sometimes we forget what we have in our hands. Another new mechanism of action is XPO1 inhibitor, that the first agent was selinexor. I have, I think, a few slides on that. And the panovinostat histone deacetylator that really didn't penetrate market that much in terms of efficacy and toxicity. The main toxicity is diarrhea, arrhythmia. And the new mechanism of action really for myeloma is coming up since a year ago. Very, very strong wave, I would say, that is anti-BCMA, B-cell maturation antigen. B-cell maturation antigen is very important in survival of B cells, even lymphoma and plasma cells, and is almost selectively is expressed on these cells. So there are conjugate antibody belantamab, mafotidine. Mafotidine is a chemotherapy conjugate, and a CAR T cell that was we had FDA approved here in the United States around 5 weeks ago, as well as the bispecific antibody. Bispecific means that you have antibody, one fork attached to BCMA, another fork attached to CD3. CD3, they are on T cells. So basically, it brings T cells next to cancer cells. Another name is T cell engagers. And so these are the new modality of therapy that I think it will be game changer, at least in terms of putting into remission the relapse patient that they didn't have any other options. However, still is incurable. So let's look at the big paradigm, big algorithm. So let's say we have a newly diagnosed myeloma that is transplant ineligible. Transplant eligibility is based on age most of the world, including Europe. However, here really we don't look at the age, we look at the biologic age. So if somebody has a good performance status, good heart and good lung, usually we consider them candidate for transplant. So this is, so what we do for if patient is not transplant ineligible. A big part of if they are slightly younger age, I would say the triplet therapy is a standard of care based on SWAP trial that was complete 2015 again. VRD versus RD in newly diagnosed myeloma not only prolonged PFS progression-free survival, but prolonged overall survival. So it means that it was very important landmark trial that if you go strong at the beginning, the success at the end is much higher. This is because there was a paradigm that we were working on that for last 10 years before 2015 that, well, if we have A, B, C, let's go A and then B and then C. But 2015 with this trial and other trials, really the paradigm shifted toward the, if you have A and B and C potent agents, let's combine them up front versus just sequence them. So triplet is very important. If any patients can tolerate triplet, immune modulatory, proteasome inhibitor, and DEX, this is the standard of therapy, regardless of transplant or not. So if you don't have a patient that is fit enough for VRD, for side effect profile, you think, well, this patient it may not tolerate. There is a VRD light regimen also that you have a dose reduced, and a schedule also is once a week, Velcade or bortezomib 1.3 milligram per meter square, and also Revlimid or lenalidomide 15 milligrams. So it's a little weaker in terms of efficacy, but toxicity really you can get through the patient. At the end of the day, it matters how much patient receive therapy. That's gonna determine success of therapy. It doesn't matter what I'm gonna do or what we wanna do. At the end of the day, what patients got that, and that depends on really your toxicity profile. If really you give a toxic regimen, patients cannot get that full regimen and we won't have a response. So sometimes answer is, less is more, and you just go with the milder regimen. And if patient, of course, tolerate, you can increase the intensity and dose and so forth. Another modern approach that really with transplant ineligible patients is very nice regimen is Maya trial, that is anti-CD38 plus Revlimid and DEX. So this is a standard regimen, Revlimid, lenalidomide 25 milligram, and also Darzalex or daratumumab is nowadays we have a sub-Q formulation that is 1800 milligram flat dose versus IV that has more infusion reactions and longer infusions and so forth. So it's much easier to administer. So anti-CD38 daratumumab, Revlimid is my regimen of choice for patients for transplant ineligible, elderly, frail, because you don't have neuropathy, you don't have the GI toxicity of Velcade. Darzalex after first infusion is very well tolerated regimen. Is kind of a rituximab agents for myeloma board, if you say from lymphoma, and I think it's the best regimen. Of course, it's quite expensive, and in terms of finance, is not comparable to, for example, even VRD light, but just on the paper, you have much less toxicity with much more success in terms of controlling a disease. This is another trial that Clarion trial as well as Endurance trial. So the question is, bortezomib is better or carfilzomib? This is I would say, mostly scientific questions, and two big pharma, they were basically encountering each other. So this is a VMP versus KMP, Velcade, Kyprolis, melphalan. So it's an oral melphalan. Melphalan is 9 milligram per meter square for 4 days. Old regimen, but still for transplant ineligible patients, if especially is a cost-effective regimen. So the translation is really doesn't matter. If you do Velcade, you're going to have the same efficacy as Kyprolis. If you do bortezomib, the safe efficacy as carfilzomib. So that's the translation. Another one, the Ninlaro, that is Exazomib, is a third generation proteasome inhibitor. Also, that one also is an option that I would say, I don't know if it's available in Iran or not, but even here, you know, in compared to other agents, is not the first choice, I would say. So this is the summary of a frail patients, a transplant ineligible patients, I would say. If you have a fit patient, so you do VRD or VRD light or DORA-RD. If you have a very frail, unfit patients, it's not a bad idea you start even with doublet and build up on that. You know, if patients with frail patients comes with myeloma, if you control myeloma, they can tolerate better chemotherapy. So starting with Velcade a few cycles and add low dose Revlimid, is nothing wrong with that. If really you have a renal dysfunction, you can use Revlimid. There's a misconception here, at least in US, that many people on dialysis or significant renal failure, they don't get Revlimid. So all of a sudden, Revlimid can be dose reduced. If you have cardiac dysfunction, I think Kyprolis is not the first option. And in this age, I think there's no excuse if patient has peripheral neuropathy. If really you have Velcade, around 40% of patients, they have peripheral neuropathy. So really, if patients start to have grade 1, you have to stop, you have to shift to Darzalex, to other agents that really doesn't cause neuropathy, because most of the time is irreversible, really. So transplant eligible, that I would say depends on the policy of the country that you practice. It can be majority of patients, including US. The most of, I would say 60% of patients that I see, I consider them as a transplant eligible and begin. So transplant is the, I would say, is very unique. The most prolonged PFS, the longest remission ever anybody in the whole myeloma space showed, is with transplant. Okay, so any trial you add transplant, you at least upfront, at least you have 3 years probably, a PFS advantage. If you take the transplant out, you, whatever modality you do, you lose PFS. So this is very important. So a standard therapy, 3-drug regimen, triplet drug, followed by transplant consolidation, followed by maintenance therapy. Okay, I'm going to talk about consolidation therapy that fell off of the favor since a stamina trial. So really, at least in US, we are not doing that much anymore. So main things, triplet therapy, transplant, and maintenance, and that's the longest remission you can get. And then that's the, I think, art of myeloma therapy in 2021 is how we can get patient on the first relapse, in the first remission, in the longest remission. You know, median age of myeloma is 68, I would say. This age is very important in terms of, you know, retiring and social and financial to wrap up everything. So it's very important to give patients 6-7 years of remission if you can, because it's significant in terms of lifestyle and so forth. So again, is a comparison between bortezomib and carfilzomib as a triplet induction regimen endurance trial that really showed these are similar in terms of efficacy. In terms of toxicity, you have some difference. If you go with bortezomib, you have more neuropathy, of course, but if you go with Kyprolis, you have more cardiac dysfunction. Carfilzomib is a quite unique medication, I would say, and it seems like for oncologists that they use it first time is a very lots of try and error, lots of side effects happen. However, carfilzomib, if you want to use it, it's very important that do not use excessive hydration. It was a conception we had 2012 that carfilzomib caused hemolysis syndrome and so forth. Half a liter before, half a liter after, hydration twice a day, and patients come with heart failure very easily. So nowadays we do not do that. Very simple. Just carfilzomib is, whether it's 10 minutes infusion or 30 minutes infusion, just we give carfilzomib with some pre-meds that, steroids and Tylenol and so forth. So hydration, it should not be that much significant in carfilzomib. Another thing, patients that they have low ejection fraction, I would say less than 45, usually we shouldn't use that. Carfilzomib, one of the main side effects is endothelial injury. Endothelial injury cause the, coronary artery disease, heart failure, and so forth. So, and it's important that in these patients we avoid. Age is very important risk factor in toxicity of carfilzomib. So I would say administration of Velcade is much easier than carfilzomib. Carfilzomib, I trust in oncologists that they at least use it 5-6 times and they are familiar how to navigate the side effect and so forth. But toxicity profile is different even in centers that they use carfilzomib very often. But efficacy is the same. So again, you can use this interchangeably. Quad therapy. So this is a new theme in myeloma, that what we're going to do with this monoclonal antibody, where are there a space, where are there a spot in the front line? And there is 2 trials, Maintenance Cassiopeia trial that they will be presented the update in coming ASCO in a week or 2 weeks from now, and Griffin trial. So Cassiopeia trial is daratumumab plus VTD, Velcade, thalidomide, dex. That is mostly European regimen, and I think in Iran also I've seen many patients they have used thalidomide in the past. And Griffin also is Darzalex or daratumumab plus VRD. So translation is, we can talk about these trials and pros and cons for a long time, but translation is, if you have a high-risk disease, especially 3 categories, that 17p, 414, and 1416, these 3, the main consensus of field is quadruple therapy can be better regimen than triplet. It means adding daratumumab, and there is plenty of data that is safe, and you can get to very nice deep response, the minimal residual disease negative with transplant. That's the best modality. If I have a patient, young patient transplant eligible, high risk, I would say quadruple transplant and then maintenance therapy. This is the best way that you can get to very low disease burden, that is minimal residual disease negative. So I will skip the details of these trials, that but that's the nutshell, that field is moving toward quadruple for high risk. High risk, you have another high risk, that 1Q gain also. 1Q gain is not as high risk as 3 category that I mentioned. And if you add 1Q gain, almost half of your patients are high risk. But if you exclude 1Q gain, only 20-25% of your patients are high risk. So this data is applicable to true high risk, that is only 3 cytogenetics, 17p, 414, and 1416, not 1Q gain. But sometimes people with 1Q gain, when nobody asks them about resources, they do that. I don't think anything is wrong. But so let's look at the consolidation and what is the role of tandem transplant. That historically, it was done very often, I would say, before 2015, before a stamina trial. So this is the IFM trial that proved transplant is a standard of care. This is a transplant in compared to VRD. It's a non-transplant modality versus transplant modality, that showed the PFS is significant. OS was not significant in this disease, but it's a very short follow-up. So the more follow-up is coming, that shows that really transplant can get to much deeper response and so forth. So transplant is a standard of care. If somebody can get transplant, should get transplant. I think transplant, in compared to other modality of myelomotherapy, at least in US, is much more cost effective. And patients sign up 2-3 months to gain 2-3 years of remission. This is the way I would put the toxicity versus benefit. A stamina trial. So in this trial had 3 arms, that you have 1 transplant plus maintenance, you have 2 transplant plus maintenance, you have 1 transplant and consolidation, and then maintenance, and showed the outcome exactly is the same. So the PFS is the same if you do 1 transplant, if you do 2 transplant, if you do 1 transplant plus consolidation. So why we should do consolidation or second transplant? So a standard is only 1 transplant, high dose melphalan, 200 milligram per meter square. Of course, when you get a little elderly age, above 70, I would say 140 milligram per meter square is probably safer choice. But if patients that they can tolerate 200 milligram per meter square melphalan, that's the choice. As I mentioned, PFS OS in this very important, very landmark trial that really answered lots of questions about consolidation or tandem test. So no need for tandem or consolidation based on stamina trials. That another one, HO1 trial that is a little complex design that it answers 2 questions, basically transplant versus non-transplant modality. Non-transplant modality here is VMP. Is a Dutch, basically is a European trial. So VMP is mostly the induction regimen in Europe back when this trial was designed, that showed that transplant is better than doing non-transplant. And then it shows that consolidation really, as you can see, the overall survival in VRD consolidation versus no consolidation is the same. So no consolidation. Coming to maintenance therapy. Maintenance therapy across different diseases, across different studies shows really we have a significant PFS as well as OS. So the most common maintenance therapy is Revlimid, lenalidomide, 10 milligram. That's the standard dose indefinitely. There is no 1 year or 2 year or whatever. As upon progression, if patients can tolerate, you can dose reduce, you can play with the frequency and so forth. But if you get patients on maintenance, that's the best way that you can prolong survival. Different subcategory, high risk, ultra high risk, standard. There is other maintenance modality that are quite more expensive and less effective if patients cannot tolerate Revlimid, including Exazomib based on thermalin. Another important study that is the Emory trial, basically, that doesn't compare actually, the study VRD maintenance in high-risk disease. The question is, what is the maintenance regimen for a high-risk disease? A study shows that Revlimid by itself is not the best option. The best option if you combine immune modulator agents, Revlimid with proteasome inhibitor. So the longest PFS that we have in high-risk diseases with VRD maintenance. So if I have a high-risk patient, I would do this. I would do quadruple therapy, Darzalex VRD, transplant, maintenance combination of Velcade and Revlimid. Velcade usually is like 1 milligram per meter square. Every other week you can go, you don't have to go that extensive for trial, because if you go, every week 1.345 years of Velcade, majority of patients have neuropathy, and that's not the way we want. So 1 milligram per meter square every other week of Velcade is well. So if I want to put it in the nutshell, you have an induction regimen. VRD is preferred based on toxicity profile. VRD, you can do that. High-risk disease, quadruple therapy, Dora VRD. Consult with transplant. I think every patient with myeloma that they can walk, they should be evaluated by a transplant center to adjudicate when is the time for transplant and so forth. And maintenance, Revlimid for a standard risk, and combination Velcade Revlimid for high-risk disease. So for, let's say, patients goes to remission and for first relapse, there are plenty of agents. There is the classic, I would finish in 5 minutes probably, then open I think for questions. I don't want to be boring that much, but so the first relapse, you have plenty of options, and there is lots of this triplet versus quadruple that is the purpose is FDA approved. So you have the Exazomib Ninlaro, you have elotuzumab anti-CS1, and you can rechallenge with Kyprolis. You can rechallenge patient with Darzalex. If patient hasn't been on Darzalex, for example, a standard is triplet transplant maintenance, you can easily use Darzalex in combination, a variety with the Velcade, with IMiD, with pomalidomide, and so forth. So I would say first relapse is you look at your patients, what they didn't have, and start to put them back on Darzalex first, I would say. If they haven't been on Kyprolis, is an option. And if they have been on Revlimid, and if you want to use immune modulator, I think Pomalyst is the best option. Pomalyst is a third generation IMiD, FDA approved 2012. And we can go through different trials in details, but as I said, the paradigm is you look at your treatment history, see what patient didn't have it, and then reintroduce. One of the trick that many oncologists actually, one of the, I would say, traps that many oncologists they get into, that they start thinking treatment without proteasome inhibitor. Is very important, because nowadays we see patients 4 months got bortezomib, then transplant and maintenance, and then patient goes on daratumumab and pomalidomide, and it still is sensitive to proteasome inhibitor. I would say exhaust your options. If patient doesn't have neuropathies, Velcade is an excellent regimen that you can combine with Darzalex based on Castor trial and other agents very nicely. And POM is an option. So what do you want to do for third relapse, for second relapse, or third line, I would say? Again, you look at your treatment history, you look at what side effect already patient had, if patient has neuropathy or not. So Velcade is not. If doesn't have Velcade, is a good option. What is your cardiac toxicity, whether you can use Kyprolis or not, whether patient exhausts Darzalex anti-CD38 or not. If patient exhausts CD38, you have to look at options, for example, Kyprolis pomalidomide, for example, or a Cytoxan-based regimen, pomalidomide Cytoxan. There is an oral Cytoxan pomalidomide that you can use. You can use Ninlaro Cytoxan, is an oral regimen for frail. So there's plenty of agents plenty of regimen that is kind of a puzzle. You have to, but that's the steps. You look at the treatment history, toxicity profile that patients already is carrying as a chronic complication from previous chemotherapy, and toxicity profile of agents that you are considering, how they overlap, and the chance of, I would say, salvage is still second relapse is quite high. So you should keep the confidence that you can put patient in the remission. Second transplant, when we do second transplant, when the PFS from first transplant usually is more than 3-4 years. If somebody relapses 1 year after transplant, there's no point for second transplant. But I think second transplant is another modality that we can use. So I put this a few items that is very handy when you look at the patients and what regimen you want to use for a relapsed patient you are seeing in your office. If really somebody is Kyprolis resistant, usually you should consider that this patient are proteasome inhibitor resistant, because Kyprolis, at least in lab, is the most effective, most potent proteasome inhibitor. If really the myeloma cells can survive with inhibition of proteasome, it means that they have autophagy activation and so forth in the cell biology level, that they are resistant to everything. If you have a pomalidomide resistance, you probably have lenalidomide resistance also. Whether Darzalex or isatuximab, honestly, I don't know if isatuximab is available in Iran. If it's not available, you didn't miss that much, because they are very much similar to daratumumab, really. And it really, many times you see a patient's relapse and still is sensitive to agents or regimen they got 4 years ago. It means that a subclone that 4 years ago responded to that therapy, still you can have a chance that you can get some remission time, 6 months or so, until next step. So it's important that you look at patient history. If patients 5 years ago got a good response to VRD, and since 5 years ago until now, or didn't get, for example, Velcade and didn't get Cytoxan, I think a classic Cybor, the oldest school Velcade Cytoxan, is the very nice option that after 5 years you can put in remission. Even maybe is better than this fancy BCMA therapies, you know. So it's very important. And if you have a good holiday from a drug, you can really regain sensitivity to drug very easily, especially for Velcade. If, you know, here we have a FDA-approved Velcade for relapse setting for patients that are exposed to Velcade more than a year ago. So if you have a break 1 year from bortezomib, you can still use that. So these are kind of a important points. So I will, another mechanism of action that really came to market, XPO1 selenexor or Xpovia, unfortunately has lots of side effects and toxicity that we are playing with doses still. I think we use it as FDA approved, insurance pays that, and is effective, and we can put patient into remission. However, in terms of toxicity profile, still I don't think it gained momentum worldwide that we look at that as a very widely used myeloma regimen because of the toxicity. I think as a future is a new mechanism of action. So you're going to hear about this more often. So this is a STORM trial. There is a Boston trial also that was basically base of FDA approval of Xpovia and Velcade in a few months ago. I want to talk about BCMA, and I want to end here and see what other people they think about you know, the myeloma space back in Iran. The new mechanism of action is BCMA targeted therapy. So the first FDA approved drug was drug conjugate BCMA, that bluntumab. So you have a mafotidine as a chemotherapy moiety that attached to this antibody and attached to BCMA. So when myeloma cells, they digest this antibody, they bring this chemotherapy inside and kills them basically. So the main toxicity is eye toxicity. Again, it hasn't gained this momentum worldwide, I think, because of the eye toxicity. Before each administration of drug, we should have an eye exam by ophthalmology, fill out paper and this and that. But I think this is the first BCMA targeted therapy. So another one that I want to talk about that is BCMA CAR T cell. That the first one got approved here, I think 5 weeks ago, and everybody is very excited. And I think many patients that they were pre-hospice, really, they didn't have any other options. We are able to put them in long remissions. So there are a variety of this is coming on the market. So the idea is, what is CAR T cell? We take patients' immune cells, you know, you do CD3 from the peripheral blood and genetically engineer them, that in the way that they attack the any cells has a BCMA on the target, and we re-inject this CAR T cell, these T cells, genetically engineered T cells, to the patient. So if you look at the schema of these CAR T cells, you have a basically a receptor that is designed for BCMA receptor. When these CAR T cells, they attach to BCMA target, they activate and they recruit other immune cells and generate the immune response against the cancer and kill the cancer. So there's a race that what target we do. BCMA, I think, is the first one. We are working in our center on three targets on one CAR T cell. So it's an extensive discussion, but I would say it's not an easy therapy. It's kind of, I would say, from the toxicity profile, is kind of a mini transplant. You know, there is lots of unpredictability, I would say, especially in neurologic side and cytokine release and so forth, but it's doable. You have to, you know, join with the big pharma that they can generate and engineer CAR T cell. But just, you know, about this new modality of therapy that is CAR T cell and a new target that is BCMA. CAR T cell is, I think, for lymphoma, for ALL, and so forth. We are using that, but that was the first one that in myeloma. Another one is bispecific one, and that's the last one. Bispecific one, it means that you have a CD3 and BCMA on one antibody and bring the T cells next to myeloma cells. So they are T cell engagers. That's also is very important, especially for, you know, here rural areas, community hospitals that they don't have access to CAR T cell. They can administer this drug, as well as other countries. You know, not every country has access to very advanced cellular therapy labs. So this is an off-the-shelf drug that you can administer. So it's much more higher market penetration. So I would end here, and I would say Sahar or Marjan, if you guys want to take over, and let's see what we can talk. Thank you so much.
Thank you. Thank you so much, Dr. Malek, for your outstanding practical and educational lecture. Thank you so much. As long as our participants ask their question, I would like to say something about, actually, in the following, I will talk about some problems in Iran. But first, I would like to say about serum protein electrophoresis tests and free light chain assay are available in more than, I think, 90% of reference laboratories, and fortunately. And based on and about, I have another comment about based our experience about daratumumab, Darzalex, we think is more attractive than carfilzomib in Iran. So firstly, I would like to say, Dr. Malek, I'm so curious about your common practice, your daily practice. You know, do you put all your patients on clinical trials? If you are working in community hospital, so you have to treat your patients according to their protocols, but maybe you have some patients you treat as you like, as you preferred algorithm, you preferred actually guidelines. And I'm so curious about your preferred guidelines. Which one is NCCN, ASH, which one is?
Yeah.
So, yeah, please.
No, I think that's the very is an interesting question, I would say, and we can talk about that. So, you know, if you look at the papers and the statistics in United States as a general, only 5% of patients they got on clinical trials. Okay, only 5%. Only 5%. So, and the reason is there are lots of reasons. I think comes with the structure of the healthcare in this country and so forth. In Europe, much more. I think UK in England, there is the data that 35% of patients they go on clinical trials, and the reason is they have a public health, they have a, you know, top to the bottom system that they can design. Okay, anybody newly diagnosed multiple myeloma goes on this trial, this and that, and across the country everybody goes, and pharma fund the medication, so it's cheap for public health and it's win-win situation. If you look at the most of these landmark trials, they ran in Europe, not in US. They put a few of US centers that they look like international, but mostly they happen in Europe because they have fast recruitment. They can do 1-year trial versus 5 years trial. In US, that time is very important. So I think it depends on where you practice. I would say in countries, Canada, Australia, UK, these are that you have public health. I think is much easier to streamline everything through the clinical trial. Here, we don't have that structure. However, when you come to academic center, that I would say clinical trials is much more, rate of enrollment is much higher. We, as our center, for example, we like to have a portfolio of different clinical trials for different patients. So, for example, I have a newly diagnosed high-risk trial that I like patients put to that. But around, I would say, only half of them, they are eligible, or maybe less than half even. Why? Because one patient doesn't want it. There is a lots of, I would say, lots of history in terms of ambiguity of clinical trials, and we don't want to be experimental and so forth. Or patient really doesn't meet the criteria. You know, you have around 30% renal failure on patients. So whether patient, if they are not eligible, for example, due to renal failure, then I have another clinical trials that it does only for renal failure. It's a little less sexier questions, but still it's clinical trials. So we like to you know, involve patient clinical trial. The reason is at the end of the day, if you don't treat patient on clinical trials, you don't learn really. You know, as an individual, you may learn something, but as a field, as a society, that we are destined to cure myeloma at some point and progress the field and push the field forward, is really we cannot learn anything. The only way that we can say we were wrong, we were right, and tomorrow we're going to be better is with clinical trials. So that's the concept on that. We have trials for relapse and so forth. So answer your question, not at all. There is no, our number is not even close to all patients or anything like that. Probably I would say 20% in the academic centers like us in United States, maybe 30% they recruit on clinical trials. In Europe is across the country, across the whole network is much higher. In US, across the whole public system is only 5%. It's quite embarrassing, I would say.
Thank you so much. Dr. Farzaneh Ashrafi has a question. In transplantation in eligible patients who are on triplet drug regimen, how many courses of treatment would you recommend? And what about, can you hear me, Dr. Malek?
Yes, I think I can repeat question if I, so okay, the question is for a transplant ineligible patient, let's say they're on triplet regimen, how many cycles, how long you continue triplet regimen before you move to maintenance? That's the question.
Yeah, I think it is. She's how many courses of treatment in eligible patients would you recommend? Triplet drugs, actually, and
eligible transplant eligible.
Ineligible, yes.
Ineligible. So people they cannot have transplant, right?
Yeah.
Okay, so that's another very important question of field. I would say that. So let's say if you have a transplant eligible, if a patient that goes to transplant, so you have a goal that get patient to transplant, get to at least very good partial response. That means you have 90% reduction. So you have a goal, and you know that you go 4, 6, 8 cycles to get to that goal and get to transplant. But for a transplant ineligible patient, so the question is, how long we're going to continue this triplet? We can't go all the way. So there is a trial called Vrd trial, F-O-R-T-E, that is comparison of transplant versus non-transplant modality. And non-transplant modality is 1 year of KRD. And that trial is the closest non-transplant modality that anybody showed, basically, the best non-transplant modality. And other trials also showed that the longest regimen is better. So translation is this, that what I would do, 1 year of therapy, 1 year of triplet, even VRD light, but continuous long-term 1 year is the best efficacy that you can get, even close to transplant. Although patient is not transplant eligible, but if you do 1 year of triplet regimen, I would say is the best outcome you can have, and before moving to maintenance. So if I have a patient, let's say 75-year-old, that we don't want to do transplant, I get them on VRD light, Velcade Revlimid light, for 1 year, and you should have a very low threshold to stop Velcade. Stop Velcade, because 40, 50% of patients, they're going to have neuropathy, and age of 75, you give neuropathy, and walking and quality of life really impacts. So in that patient, if Velcade really caused neuropathy, I change it to daratumumab and Revlimid. As Sahar mentioned, I think daratumumab in an environment like a patient that in Iran, it will be more valuable than Kyprolis, because when patients they already get to Velcade, some fraction of them they are resistant to proteasome inhibitor. But if you try a new class of medication, anti-CD38, I think is the better approach than reusing another proteasome inhibitor. So if a patient has neuropathy, I change Velcade to Darzalex. I go Darzalex Revlimid and continue for at least 1 year before going to maintenance. I don't know if I answered the question or not.
Yeah, thank you so much. I think Dr. Hossein Qasemi has some question that Miss Sadeghi, sorry, because
yes, Dr. Tavakoli, Dr. Qasemi has the microphone.
Okay, thank you so much.
By himself.
Hello, do you have my voice?
Yeah, please, yeah.
Okay. Hello, Dr. Malek. Thank you for your nice and warm and clinical presentation. I have some questions about the multiple myeloma. You know that in Iran we have some restrictions. Because of the price of the drugs, we don't have plenty of these regimens. So we just have some regimens like VTD, VRD, and VMP, or maybe bendamustine. So in other drugs like Darzalex, pomalidomide, or carfilzomib, another, we can't. Our patients, on the whole, we can say, afford to get these drugs. So we have another problem, which in bortezomib. I don't know, because of the Iranian form of these drugs or the natural form of the drug, our patients have a problem with its side effects, neuropathy. So they can't tolerate the extent of neuropathy after maybe we can say 4 or 5 cycles of using bortezomib. So we have problems in using bortezomib in our, as you know, drugs. So what can we do? Can we increase the period of as you know, bortezomib, or halve we can say the dose of the bortezomib in our regimens? Thank you.
I think that's the challenge, and is very relevant, because I would say if you go bortezomib twice a week, that classic VRD that is 21 days and day 1, 4, 8, 11, twice a week bortezomib, the chance of neuropathy is very high. Very high. Even when I use triplet, barely I use twice a week. The patients that I use twice a week, honestly, there are patients that have light chain nephropathy. I'm very nervous to control this disease very fast. So that's the only subset of patients I use twice a week. Everybody else should have once a week. Once a week, sub-Q, not IV. IV also causes more neuropathy. We know that. I think sub-Q is the most worldwide use of bortezomib. So if I want to answer your question, I would say the first solution, it might be that we don't do twice a week at all. Okay, so once a week. Velcade is the best medication for myeloma if it didn't cause neuropathy. It's very important. And unfortunately, in the last 20 years, that there's been many studies that how we can come up with a drug, some sort of protein, some sort of protective measure that we protect patient against neuropathy. You know, this neuropathy is not the result of proteasome inhibition, is the boron base. Basically, bortezomib is boron base, and that boron hurt the nerve. If you go with Kyprolis or carfilzomib doesn't have neuropathy at all because it's not boron based. So I would say the first solution is don't use twice a week. That's too much. you go slow once a week. I think that's the best strategy. At least you can save, I would say, 30–40% of neuropathy at the beginning. You won't run to neuropathy. And then, but if you keep going, at some point you're gonna have neuropathy, right? In that situation, so I would say transplant. Transplant is the main one, and I think Iran is one of the best, probably best Middle East center that they can do transplant. Okay, so transplant is the best option that you can save patient from more chemotherapy and more side effects, obviously, right? So I would say get the patient at least to partial response, preferably very good partial response, but get partial response and transplant them with the high dose melphalan. So high dose melphalan, if you scratch transplant, then you're gonna need lots of non-transplant modalities that, whether medication they are expensive or they don't have it, or the patient had already toxicity, we cannot use it, and this and that. So I would say transplant is the main things that in the big picture we can gain. Other thought that I have considering your question is the Darzalex is very important, but if you don't have access to that, and you don't have access to carfilzomib, and you don't have access to pomalidomide, another option is Cytoxan. So Cytoxan, as I mentioned at the beginning, is an agent that is very important, and in the setting that the practice that you mentioned, I think is very important to consider that. So if a patient has a, can you hear me?
Yeah, I hear.
Okay,
Yes,
I'm sorry. All of a sudden, so in this situation, I think Cytoxan, reintroducing of Cytoxan is very important. So let's say if a patient, you are practicing in the area that you go with Velcade once a week for, I don't know, 5 months, 6 months with Revlimid and Dex, and really patient has bad neuropathy. So
yeah, use it regularly. We use VCT regimen.
yeah.
But another question, Professor, excuse me. After transplantation, we should use bortezomib or Velcade as a maintenance therapy, as we read in our guidelines, NCCN or other references. So this neuropathy of bortezomib has the problem which we can't use it again. My question is that, can we halve the dose of bortezomib, for example, bi-weekly, or the half the dose of the bortezomib weekly? Can we use?
So you're right. So I would say if you want to use Velcade as a maintenance option for a long period of time, the dose should be 1 milligram per meter square every other week, sub-Q. So, and every other week, even I use it in patient with neuropathy, that neuropathy didn't get worse. Really, I think is neuropathy safe dose. So that's my only suggestion, really. Otherwise, as you mentioned, I mean, Velcade and neuropathy is the main challenge. But I think the art is, the main things is many times there's no escape from that. But if I think we for maintenance every other day, 1 milligram per meter square for upfront, once a week, not more than 1.3. If patients has a time, again, you know, myeloma, if patient doesn't have renal failure, for example, for renal failure, you are very nervous to control your disease as soon as possible to save your nephrons, right? If patient doesn't have renal failure, doesn't have a huge disease burden in the bone that you are not dealing with fracture or so forth, patient has only anemia, it's not anything wrong with that. If you go 1 milligram per meter square of Velcade weekly, start slow and then build up on that, the chance of neuropathy is much less. So
thank
again,
you. Welcome. Sorry, we have many questions, because I think my question can cover all of your question, our participants. Sorry, Dr. Malek, as you know, to determine whether the myeloma patients categorized as standard or high risk, doing cytogenetic and fish studies is mandatory, necessary. Unfortunately, these tests can be done only to some and few reference laboratories in Iran, in capital cities like Tehran, Shiraz, Isfahan, Tabriz. Consequently, we usually face to significant number of referral patients for bone marrow transplantation because we don't have any other choices. Actually, by this, while without any this test, FISH and other tests, just only a preliminary tests like LDH, albumin, and so on. But so without aforementioned test, FISH or cytogenetic, I think without doing this test, risk stratification, so decision making, whether they are eligible for early transplantation or late transplantation is not possible for us. Actually, we left with no choice that just do bone marrow transplantation for all our patients and follow them with maintenance with lenalidomide or other drugs according to patients' compliance. I would like to know about, do you have a similar situation like us in somewhere in US? And if you have, what's your recommendation? What's your
I think this is a very important question, but the answer is you didn't. I don't think you're gonna miss that much. The reason is this: if really, the only reason I want to see a risk stratification upfront, whether I want to do quadruple versus triplet. If you don't have access to daratumumab upfront, there's no reason that you have to know cytogenetics, okay? Because patients are going to go to triplet regimen anyhow. You mentioned about late versus early transplant. That also, in this age, I think late transplant is not a standard of care. Here, everybody goes early transplant. So basically, as you mentioned that you were asking anywhere in US they do such a thing. I said, well, everywhere in US actually they do early transplant, regardless of risk stratification. So the knowledge of patient has risk stratification really doesn't matter whether patient minimum should have a triplet. That's everybody should have it. Everybody should have transplant if they can, and the ability to receive transplant is not dependent on cytogenetic, it depends on the organ function. So I would say you didn't miss that much. However, the standard risk and cytogenetic and high risk is really can predict your future quite often. If you have 17 remissions, they are very short if you have a standard, so you can plan more robustly, I would say. But for upfront, I don't think you are missing that much if you don't have a high cytogenetic.
Dr. Tavakoli, may I ask you a question? Is that okay? So unfortunately, it sounds like Dr. Mousavi had some technical problems, but I have a question that was sent to me, so I asked on his behalf. So the question is about second transplant, either auto or allo transplant, and I don't think he meant the planned tandem transplants. I think transplant in the relapse setting after the first auto. And if you can comment on the situation where you have already collected enough cells for 2 transplants versus the situation that you only have cells for 1 transplant. So basically, role of second transplant, allo versus auto. And I think that covers one of the questions in the chat box too. Thank you.
Yeah, wonderful. So second transplant, I think, is very important modality of therapy in many settings. So if you have a PFS more than 3 years after first transplant, second transplant with leftover of cells and probably 140 milligram per meter square of melphalan, it can give you less PFS, but significant. For example, if somebody has 5 years PFS after first transplant, second transplant probably 3-4 years is possible. But if somebody has less than 3 years, let's have only 1 year of PFS, second transplant can give you 8 months. So it doesn't worth it really. So answer to that question, I would be that It depends on the PFS after first transplant, if patient is melphalan sensitive or not. So that's with leftover cells with 140 melphalan, I think is a very valid option in a situation like that. Allo for transplant, allo for myeloma, unfortunately, has not panned out that much. The reason is the risk of GVHD for myeloma somehow is way higher than other settings. So at least in US, allogeneic transplant is for clinical trial setting, not a standard of care. So we don't offer allogeneic transplant for any patient. However, in some setting with the young patient, high risk cytogenetics, we like to apply insurance and so forth because it's worth it. It gives a long-term graft versus myeloma, but still is an area of research, I would say, and lots of toxicity.
Thank you so much. Ms. Sadeghi, please on microphone of Dr. Modir. I think Dr. Modir Amani, I omit Modir Amani. Yes, please.
I send the request, yes.
Dr. Modir,
do you,
yeah,
yes,
please.
do you hear my sound?
Yeah, please.
Yeah, thank you, Dr. Malek, for your nice lecture. I have a question. What is your best options for treating the Velcade neuropathy if it's existed? Because many patients in this regard have a lot of problem about this neuropathy. What's your best options?
Yeah. So the answer, unfortunately, is we don't have any option. So the unfortunately the neuropathy most of the time is irreversible. Rest of the life patients has this. We have some medication that we can mask neuropathy. There is no agents that can reverse or cure neuropathy other than a smart oncologist that stop Velcade when it's necessary, basically preventing neuropathy. The way that I play with gabapentin is very important medication for neuropathy because I think is underused. I think gabapentin is in Iran available. The way I would do that, I would go 300 milligram every 8 hours TID basically. And then every week patients add 100 milligram. So goes 400 milligram TID, 500 milligram on a weekly basis, all the way to 1200 milligram TID. If you give 1200 milligram TID to patient right up front, they go to coma or something. But if you do gradual increment, is patients tolerate much better, and at some point, majority of patients, in my experience, they have a good disease control, neuropathy control. 900 TID, sometimes you have to get to that. But the art is you have to start slow and build up on that. You can't just prescribe 900 TID up back front. Patients, they cannot drive and so forth. Then 300 or 100 TID doesn't work, and patients, oh, well, this medication doesn't work. Every week you build up on that 100 extra until neuropathy is controlled. Sometimes we use Lyrica also, other things like nortriptyline and these things that sometimes we use. But the first line that I would exhaust it, and the best experience I had at least, is gabapentin, neurontin, go all the way to 1200 milligram TID. That's the only things can help. Other than that, nothing else can do that.
Thank you so much. Dr. Ashrafi from Isfahan has a question. In HIV-associated plasmablastic myeloma, what would you recommend?
Yeah, I would say the terminology, this interface of lymphoma myeloma is a debate about terminology. I would say plasmablastic. So there's not much HIV-associated myeloma, I would say, in contrast to HIV lymphoma field that is different. So HIV myeloma is not HIV-defining malignant hematology disorder. Mm-hmm. And most of the things that we were calling plasmablastic myeloma right now are plasmablastic lymphoma, in fact, and they go to lymphoma regimens that, in lymphoma world, the EPOC and so forth. So I would say if there is no HIV myeloma associated. So most of this plasmablastic, they were treated as a myeloma, of course, with the extensive heart medication and controlling HIV plus lymphoma. That should be the standard.
I can make a quick comment as a lymphoma doc. So yeah, we use lymphoma regimens like our EPOC, but we add Velcade because of the myeloma features. And there are case reports of using anti-CD38 antibodies. And you got to do your best at the front line. So those patients usually get a transplant, auto transplant in the first remission. And because if they relapse, there's not much to do. Sorry, just a quick comment on the question.
Thank you, Marjan.
Thank you so much. Dr. Malek, and in the following, do you have any change in your practice, in your protocols and regimen during the COVID-19 pandemic?
Yeah, so that was a moving target, basically. So what we did, we held the transplant for 6 months of first COVID, and we resumed that. So far, the data about COVID that we have on myeloma, most of myeloma patients that they die from COVID is due to uncontrolled disease, not because of therapy. That's what we know. That majority of patients, they have newly diagnosed myeloma or fresh relapse myeloma, and that's kills the patient on the COVID setting, not patients that they are on Revlimid and they get COVID. So if the best way to prevent COVID-related deaths is controlling disease very aggressively and keep patient on maintenance, there's no data that suggests if patient, if for preventing COVID infection, we should go off Revlimid. There is no such thing. In fact, if patient relapse, there is an increased chance of that. We do transplant right now. Majority of our patients, they are vaccinated, but even they are not vaccinated, I would proceed with transplant because transplant is the best modality to control the disease. How much really there is a chance of COVID post-transplant? That's the, I think, main question that is a transplant center in Iran they can ask. I would say the best answer is unknown. However, the data from large centers, even large New York centers, that they were doing transplant all the way to March, January 2020 to March 2020, when COVID was in New York and they didn't know and they were doing transplant. There is no increased mortality from transplant in the COVID era. So far, what we can say.
Thank you so much. I'm so sorry because I can't cover all your questions, dear participants, but at the end, I would like to say something, our problems, and how we treat multiple myeloma in patients. Given that in Iran, we are facing many restrictions, including prescribing new drugs, actually crippling sanction, difficulty money transfer resulting in restriction prescribing new drugs. So I think we need more interaction with the world, what is going on. And I think we need more collaboration with our colleagues, Iranian physician working abroad. So because as we can communicate together in a better manner, so easily. And I would like to say, as in Iran, transplantation is not expensive and is affordable by patients and is supported by some government committees. So we can do easily for our patients. And I believe that Iran is not a part of poor resource country. If you have money in Iran, you can have anything in the world. You can buy such new drugs and it's available for you. But I think it doesn't mean we can offer these new drugs easily for our patients, because I think more than 90% of our patients are covered by insurance company, and insurance company don't cover these new drugs because their high prices. And similarly about basic insurance company do not reimburse price to the patients. At the end, I would like to say a special thanks to my colleagues in Iran. Despite all restrictions and limitations, I believe they are doing the best maybe this maybe not is according to guidelines, but in some extent they are doing the best. Actually, I believe they choose suitable treatment with least facilities. Thank you so much. Is there any question? Dr. Shadaman, Dr. Malek, thank you very much.
I would say thank you. Thank you. You guys, you're awesome. Although you're from Danishgah Tehran, but you're awesome. And hopefully we can see each other further. And yeah, my email is online. And anybody, if I can help anyway, I'm happy to do.
Thank you so much, Dr. Shadaman.
No, yeah, I just wanted to thank everyone. There are a few questions. I didn't know if you're out of time or we could do 10-second response to each question. Or I don't know, Dr. Yaghmaie, Dr. Tavakoli, is that it? Or do we have like 2 minutes? I think Dr. Najati had a question. Anyway, so I'll leave it to the moderators, but I just wanted to point out that there are a few questions that have been asked.
There is many questions. I can moderate.
Yeah.
Sorry.
Okay, well, maybe they can touch base with Dr. Malek later on email or something.
Yeah, my email, if you just, I mean, you are welcome to share my email with anybody, Sahar.
Yeah, thank you so much. Hope to have better future for our patients. Thank you so much. Great. Have a time. Thank you so much. Goodbye.
Thank you.
Thank you.
Thank you.
Thank you, Marjan.